Alrighty guys, it's Jamie Batts, your instructor for Bio 109, and we are diving into Chapter 18, which is our reproductive chapter. Let's get started with all of this new stuff. Last week's chapter was a bit intense with all of the physiology of acid-base fluid balance as well as all the kidney stuff. This week is more straightforward, stuff that you're probably already familiar with. We'll skip over the learning outcomes. They're already in your chapter folder or weekly folders. The reproductive system overview. They both sexes have the same basic components. You have gonads, which are your reproductive organs. They're producing the gametes. They're producing the hormones. You also have accessory glands and accessory hormones to secrete fluids and support the reproductive structures. And then there's the external genitalia, which you're probably already familiar with at this point, right? The gonad is the testes in the male reproductive system, or the testis, which is the singular. This produces the male gametes, or the spermatozoa, the sperm. The accessory organs are the seminal glands, the prostate gland, the bulbourethral glands. These all have input into the semen. They all have secretions that go into the semen. The male reproductive tract includes the epididymis, the ductus deferens, which is formerly called the vas deferens, and the urethra. The external genitalia is the scrotum and the penis. There you see all of the accessory structures, the gonads, the external genitalia, and we'll get some more close-up views so you can see how everything is interrelated in there. The path of the sperm, it flows from the epididymis, which is the site where the sperm are forming, into the ductus deferens, into the ejaculatory duct, and then into the urethra. The accessory organs are secreting various fluids into the ejaculatory ducts and the urethra, and then the external genitalia, the scrotum, encloses the testes, and the penis is the erectile tissue through which the urethra passes. So here you see where everything happens. The testes, which is where the sperm are growing. The epididymis, which is where they're kind of housed until they're ready to be released. This ductus deferens, or vas, it's formerly called the vas deferens, comes up and around behind the bladder. And here it meets with its first extra juice that goes into the sperm. This is from the seminal gland. And then the sperm and the seminal secretions will pass through the prostate. Then they'll pass through where this bulbourethral gland is. This is called the ejaculatory duct. And the bulbourethral gland has its own secretions, and then it can leave the body down the urethra. There are some other muscles involved here. The dartus muscle is a smooth muscle in the skin of the scrotum. It makes the scrotum wrinkle. And then the cremaster muscle is going to move the testes up into the body or allow them to descend. There's a serous membrane that surrounds the scrotal cavity. There's also a tough fibrous capsule that covers the testes to protect them. And then the lobules within the testes contain all of the seminiferous tubules for sperm production. The testes shaped like a flattened egg. The sperm are produced within the seminiferous tubules, and the sperm are moved to the rete testis, which is a maze of passageways, which are connected to the efferent ductules, and those efferent ductules merge into the epididymis. So all of these little tubules in here are the seminiferous tubules where the sperm is created, and we'll look at the structure of those in a second. Then you have the efferent ductules, which lead to the epididymis. And the epididymis is, again, where the sperm kind of wait and hang out before they're ready to leave. Spermatogonia are the stem cells, which are living in the seminiferous tubules. They're diploid, meaning they only have half the number of chromosomes, or they have all of the chromosomes that they need, 23 pairs. And then through the process of spermatogenesis, they will produce haploid cells, which only have half of the number of chromosomes that they need, which are, the sperm. Normal adult males producing 100 to 200 million sperm per day. Holy moly. Spermatogenesis is a 4-week process, so it takes 4 weeks for these sperm to form. Mitosis of the spermatogonium produces 2 daughter cells. One spermatogonium stays and will stay as a new stem cell, and the other one will become a primary spermatocyte. The primary spermatocyte will undergo meiosis 1 and produce 2 secondary spermatocytes. Those secondary spermatocytes will have 23 chromosomes. Meiosis 2 is when the second spermatocyte divides with 2 haploid spermatids. And so there's 2 divisions that take place. Ultimately, 4 spermatids are produced per primary spermatocyte. Spermiogenesis is not the same thing as spermatogenesis. Spermatogenesis is the forming of the sperm. Spermiogenesis is the physical maturation. So this is another 5-week process. Their spermatids have to mature into spermatozoon or sperm. So here is the overall process. Spermatogonium divide, produce another spermatogonium and a primary spermatocyte, undergo DNA replication, produce secondary spermatocytes. These secondary spermatocytes will divide again, and now we have haploid cells that only have half the DNA that they need. The DNA is no longer, the chromosomes are no longer paired up. They're called spermatids, and then spermiogenesis has to occur in order for them to have the flagella and all of the things that they need in order to survive. So overall spermatozoon structure. They're very specialized to deliver the chromosomes to the female gamete. They're very, very small, no organelles, no intracellular structures. Acrosome is the, it's kind of like a little hat on the top of the sperm, and this is where special enzymes are needed to break into the egg cell. The head contains the nucleus and the chromosomes, the neck contains the centrioles, and the middle piece contains the mitochondria for ATP production so that that little flagella can move. The tail is the flagellum, and sperm are the only cell in the human body that have a flagella. So again, acrosome has all those enzymes, head, neck, mid-piece, and then the flagellum. You can pause the video here, go back and review this first section. Testosterone is produced primarily by the interstitial cells of the testes. They're cells that are outside of the seminiferous tubules. Within the seminiferous tubules, spermatogenesis and spermiogenesis occur within the cytoplasm of the nurse cells. Nurse cells play a role in hormonal regulation. GnRH, gonadotropin-releasing hormone, comes from the hypothalamus, and it stimulates the anterior pituitary to release LH and FSH. LH, luteinizing hormone, targets the interstitial cells, increasing the testosterone production. FSH, follicle-stimulating hormone, is targeting the nerve cells of the seminiferous tubules, promoting spermatogenesis and increasing inhibin. Inhibin is going to inhibit FSH through that negative feedback loop. Here's the whole process. Hypothalamus secreting GnRH, anterior pituitary producing LH and FSH, going to interstitial cells or nerve cells, and then the negative feedback loop turning the whole thing off. Overall effects: increased spermatogenesis and spermiogenesis, and increased testosterone. Testosterone has several effects on the peripheral tissues, including maintenance of glands and accessory structures of the reproductive system, establishing male secondary sex characteristics, stimulating growth of bone and muscle, as well as affecting central nervous system, including libido, sex drive, and other related behaviors. You can pause the video here, go back and review this section. Capacitation is the last little part of sperm formation. The testes produce the sperm. The sperm are stored in the ductus deferens for several months, as well as the epididymis. Other parts of the male reproductive system are responsible for maturation, nourishment, storage, and transport. The spermatozoon have to go through the process of capacitation in order to be fully functional. So in other words, you can't just take sperm directly out of the testes and expect them to fertilize an egg. They're not going to be able to swim. They're not going to have the ability or the capacity to do that. The spermatozoa are more motile when they're mixed with the secretions from the seminal fluids, and they become capable of fertilization when they're exposed to the female reproductive tract. So in other words, they're incapable of fertilizing unless they're within the female reproductive tract. The seminal glands, or the seminal vesicles, contribute 60% of the fluid to semen. The ejaculatory duct carries the fluid from the seminal gland to something called the ampulla, which is basically an enlargement at the end of the urethra. The prostate gland encircles the urethra as it leaves the bladder, produces a little bit of semen secretions as well. The bulbar urethral gland is at the base of the penis, and it empties into the urethra. This has a thick alkaline-like mucus that lubricates the tip of the penis, helps neutralize any urinary acids that are within the urethra. So here you see in detail what some of these structures are. You have that ductus deferens coming in from the testes. The seminal glands are just located right here where the sperm and the semen can first mix. Then there's some more secretions from the prostate. This is at the entrance to the urethra. And then the bulbourethral glands are right here at the base of the prostate, and they have a secretion as well. You can pause the video here, go back and review this section. The penis structure, most of you are probably familiar with this, especially if you're a male. It's a tubular organ containing a urethra, conducts urine to the exterior, as well as introduces semen into the female reproductive tract. The root is the fixed portion attaching the penis to the body wall, and the body is the shaft. It's the tubular movable portion of the penis. The neck is the narrow base between the shaft and the glands, and then the glands is the expanded distal end surrounding the external urethral orifice, and the prepuce or foreskin is the fold of skin that is around the tip of the penis. So the penis is made of two different types of tissue, the corpus spongiosum and the corpus cavernosum. The corpus cavernosum is the erectile tissue. The spongiosum is the extra tissue that's in there. So let's talk about this erectile tissue. It's a network of vascular spaces. At rest, the arteries are constricted. The muscle partitions between spaces, condense. In response to sexual stimulation, the vessels will dilate, increasing the blood flow, engorging those vascular spaces, causing the erection. So the skin of the penis resembles the thin skin of the scrotum. The dermis has a layer of smooth muscle that's continuous with the dartus muscle of the scrotum. There's a relar tissue that allows the skin to move without distorting the deeper structures, and the elastic fibers found deep to the areolar tissue make it able to move and go back to shape. The erectile tissues are the corpus cavernosum on the anterior surface and the corpus spongiosum, which expands to form the glands that surrounds the urethra. So here you can see a cross-section of the penis. You see the urethra and the erectile tissues surrounding the urethra, the spongiosum, and the cavernosum. You can pause the video here, go back and review. We'll talk about some prostate disorders. There's benign prostatic hypertrophy. This occurs spontaneously in men, typically around age 50, with declining testosterone production and the presence of estrogen. It can constrict the urethra severely or just minorly. Prostate cancer is the second most common cancer and second most common cancer deaths in men, and it can be screened for by a blood test looking for prostate-specific antigen, PSA, and the treatment involves radiation or surgical removal, prostatectomy. You can see it can become very enlarged and cause urinary infections. Testicular cancer is the most common cancer in males ages 15 to 35, which is fairly young, so make sure you're checking them out. Relatively low rate includes of all ages, so roughly 3 cases per 100,000 males. So it's still fairly low in occurrence. More than 95% of testicular cancers are from abnormal spermatogonia or spermatocytes. So those that have cancer can produce abnormal spermatogonia and spermatocytes. Treatment can be combined of chemotherapy or orchiectomy, which is a removal of the testes. The survival rate is 95% as long as you can diagnose it earlier and treat it earlier. There's good old Armstrong, Lance Armstrong. Ooh, I'm so bad with names. You can pause the video here, go back and review. Let's move on to the female reproductive system, producing sex hormones and the functional gametes. The other job of the female reproductive system is also to support, protect, and nourish a growing baby, fetus. The main organs include the ovaries, uterine tubes, uterus, vagina, and external genitalia. There's also accessory glands like the mammary glands and smaller accessory glands involved as well. The gonads include the ovaries, or singular is ovary, produces the oocytes that mature into the ova, which are the egg cells. The female reproductive tract has uterine tubes, a uterus, a vagina. The uterine tubes are where fertilization will occur. The uterus is where the fetus and embryo will develop, and the vagina is the passageway for the birth canal, as well as menstrual fluids and sperm deposition. The external genitalia involves the clitoris, as well as the labia, which are the external lips lubricating and guarding the vaginal entrance. So mammary glands, ovaries, uterine tube, uterus, and then vagina. Let's talk about the ovaries. The ovaries are paired. They're so there's 2, 1 on each side. They have 3 major functions: produce the oocytes, secrete female sex hormones, estrogen and progesterone, and they also secrete inhibin. So they're very analogous to the testes. They produce the gametes, they secrete hormones, and they secrete inhibin. Same thing that the testes do, it's just the female version. The uterine tube has an expanded funnel opening into the pelvic cavity along the surface of the ovary, and then the other opening opens into the uterine cavity. The uterus is inferior to the ovaries. It's angled forward and above the bladder. There's the rectouterine pouch, which is the pocket formed between the posterior wall of the uterus and the anterior surface of the colon, and the vagina extends from the uterus to the external genitalia. Accessory glands lubricate the vaginal entrance and the external genitalia, and then the external genitalia include the clitoris and the labia. So here you see a cross-section, rectum in the back, the rectouterine pouch, the uterus, ovary, infundibulum of our uterine tube coming down, emptying into our uterus. Notice how thick, that thick muscular wall of the uterus. Cervix is the opening of the uterus into the vagina. The vagina then opens into, it's called the vestibule area, or the external genitalia, where the labia guard the entrance. You see the urinary bladder here getting squished, and the urethra. So there's 3 separate holes at the end of a female. Some students don't realize that, but you should know that. So let's talk about ovarian and uterine ligaments. They're basically holding everything in place. The ovarian ligament extends from the uterus to the medial surface of the ovary. There's a mesovarium. This is a mesentery that supports and stabilizes each of our ovaries. The suspensory ligament extending from the lateral surface of the ovary to the pelvic wall. And then the broad ligament is the extensive mesentery that attaches to the sides and floor of the pelvic cavity, kind of creating this bat wing structure, broad ligament. You can see the meso-ovarian ligament, and the suspensory ligament holding our ovary in place. Other ovarian structures. It's fairly small. There's a hilum on the ovary as well. This is where blood vessels enter and leave. This is also where the ovary attaches to the mesovarium. The interior of the ovary is divided into a cortex and medulla. The medulla is where the blood vessels are. The cortex is where the follicles develop. And you can pause the video here, go back and review this section. Oogenesis is the process of creating oocytes, or egg cells. The mitosis of the oogonium produces 2 daughter cells. This is something that's actually completed before birth. So as baby girls are born, they have all of these oogonium that they need. 1 oogonium and 1 primary oocyte are produced from the mitosis of 1 oogonium cell. Kind of like this, the same thing as the spermatogonium. Then meiosis 1 occurs. This is between the 3rd and 7th month of fetal development. So again, even before baby girls are born, they're already preparing for childbirth, for their own childbirth, right? They're preparing for when they're mature enough. They're not even born yet, but their bodies are preparing them. Very crazy. So between the 3rd and 7th month of fetal development, the primary oocytes are preparing for meiosis. The process is halted after prophase 1 until puberty occurs. So they're all kind of frozen in their meiosis process. And then once puberty onsets, a few primary oocytes will continue. The primary oocyte will divide into 1 secondary oocyte and a polar body. Each will only have 23 chromosomes. The secondary oocyte gets the majority of the cytoplasm, majority of the organelles, everything. Meiosis 2 is when that secondary oocyte begins to mature. The first polar body may or may not be complete by meiosis 2. So it could be suspended in metaphase 2, and then it's ovulated or released. If fertilization does not occur, meiosis 2 is not completed. So the egg cell is just eliminated with the rest of the uterine lining. If fertilization does occur, the secondary oocyte will divide and a second polar body will form, as well as an ovum. Both are haploid, so they both have half the number of cells, and the ovum can then unite with the sperm, and the polar bodies will degenerate and float away. So this is all happening before birth. Oogonium dividing to create another oogonium, primary oocyte. DNA is replicated, primary oocytes are formed, and then at about puberty, the secondary oocytes will form. This is kind of on the monthly cycle basis, right? Once a month, one selected to kind of win the lottery. This secondary oocyte will be released, and it will continue into metaphase. And if it is fertilized, then it will develop into a mature ovum, or it will not, if it's not fertilized. So the ovarian cycle involves changes within the ovarian follicles. These are special structures that surround the developing oocytes. There's about 2 million primordial follicles that exist at birth. Each contains a primary oocyte. At puberty, there's only about 400,000 left, so they deteriorate over time. It's a process called atresia. Each month, FSH will stimulate the development of several follicles. So the primary follicle will develop, the follicular cells enlarge, divide, and form several layers around the primary oocyte. There's a clear region called the zona pellucida. The follicular cells produce estrogen to help support the growing egg cell. The secondary follicle is a wall of another wall around our follicle, and it has fluid pockets that expand and separate into inner and outer follicular layers. Then there's the tertiary follicle or mature Graafian follicle. It forms by days 10 to 14 of our ovarian cycle. The corona radiata forms around this. It's another protective layer. The expanded central chamber is called the antrum, and it has follicular fluid. And then ovulation is the end of the follicular stage and the start of the luteal phase. This is when that tertiary follicle is released, and the secondary oocyte and the corona radiata go into the pelvic cavity and into the uterine tube. Left over in the ovary is the corpus luteum. It's the collapsed tertiary follicle, kind of like the outer shell. It's just left there. It's secreting progesterone and estrogen, and it will degenerate if the egg is not fertile, if the oocyte is not fertilized by about 12 days later or so. Fibroblasts produce a little piece of scar tissue, progesterone and estrogen levels plummet, and that's the end of the ovarian cycle. And then it starts all over again. So here's the whole process. You have your primary follicles developing, and then the secondary follicles getting that zona pellucida around them, that extra layer. And then the tertiary follicle with all this extra antrum space holding follicular fluid. And then the rupturing of ovulation occurs. The corona radiata surrounding that oocyte. And then the corpus luteum is the empty shell that's left over. And it will wither away and continue to produce progesterone and estrogen for about 12 days. You can pause the video here, go back and review this section. The uterine tubes are hollow muscular structures. They're about 13 centimeters long, just a few inches long. The infundibulum is the expanded portion that's adjacent to the ovary. The fimbriae are little finger-like projections very close to, but not actually touching the ovary. And the cilia line the inner infundibulum. They kind of beat toward the uterine tube. The oocytes are transported by the ciliary movement, kind of passing them down, kind of like a crowd surfer, just passing that egg down towards the uterus. The ampulla is the middle segment. The isthmus is the narrowed portion connected to the uterine wall. There's all of those cilia. And the uterine wall is made of 3 layers: the perimetrium, myometrium, and endometrium. The perimetrium is continuous with the peritoneal lining, it's just that outer lining. Myometrium is the thick muscular layer with smooth muscle, which will contract to push the fetus out, and the endometrium is the inner lining, which is glandular, and it will grow and regrow each month, as most of us women know, and most of you men probably know as well. 2 parts to the uterus. There's a uterine cavity and the cervical canal. The uterine cavity is the superior chamber continuous with the isthmus of the uterine tubes. The cervical canal is the constricted pathway, which is at the inferior end of the uterine cavity. So here you see all of our layers. The perimetrium, myometrium, endometrium is that inner lining, cervical canal, uterine cavity. There are anatomical regions to our uterus. There is the fundus, which is the rounded superior portion, the body, which is the large portion, and the cervix, which is the narrow opening passing into the vagina. Fundus, body, cervix. The uterus is capable of great changes in shape with pregnancy. I've actually seen a dissected human uterus. It's about this big when it's not functioning. It's crazy how something this big can cause that much discomfort every month, but it does. Provides mechanical protection, nutritional support, as well as waste removal for the embryo. It's called an embryo from 1 to 8 weeks of development, and then a fetus from 9 weeks and through delivery. Contraction of the muscular wall is important in delivering that fetus. Fertilization is when the secondary oocyte is penetrated by a sperm. The uterine tube is usually the location for this. So the secondary oocyte is typically only viable for about 12 to 24 hours after it's been released from the ovary. Otherwise, it will start to degenerate. Doesn't mean that fertilization is impossible, just means it's not very likely. So it takes 3 to 4 days for that secondary oocyte to reach the uterine cavity. You can pause the video here and answer these 3 questions. The vagina is a highly elastic, distendable muscular tube. It extends from the cervix into the vestibule. The vestibule is surrounded by the external genitalia, typically about 9 centimeters long with a variable diameter. It has an internal passageway. We call that the vaginal canal. It's the passageway for menstrual fluids, receives the penis during intercourse, holds the spermatozoa before it goes into the uterus, and it also forms the inferior portion of the birth canal. It has a fornix, which are the recesses around the cervix. The ruggi are the little folds which allow it to expand, and the hymen, which is an epithelial fold that blocks the entrance to the vagina. It's stretched and torn during intercourse or tampon usage. So the hymen is this little extra piece right here, the vaginal canal with the ruggi, the fornices or fornix on either side of the cervix. See how the cervix kind of dips into the vagina. And then there's some glands that are associated with the vagina as well. The vestibular glands, they are for vaginal secretions. The vulva or pupidinum, this is the area of the containing female external genitalia. The vestibule is the central space. It's bounded by the labia minora, and the lesser vestibular folds keep the vestibule moist. The greater vestibular folds are activated during sexual arousal. Has the same origin as the bulbourethral glands in males. The mons pubis is the bulge of adipose tissue, which is deep to the skin and superficial to the pubic symphysis. The clitoris projects into the vestibule, contains the erectile tissue of the female. It's comparable to the tissue of the penis. And the prepuce is formed by extensions of the labia minora that encircles the clitoris. The labia majora are the large folds of skin that encircle the labia minora and the adjacent structures. Something about me being female, I don't know, I just don't like this view. I was never meant to be a gynecologist, I guess, but you can see these structures here, the labia majora, labia minora, the hymen, the urethra entrance, the clitoris, the prepuce, which is that extra piece of fold of skin, and then the vaginal entrance. Not comfortable looking at that. I don't know why. I don't know. I've been a female for 34 years now. Still don't like to look at that. You can answer these 3 questions here. Mammary glands, last little section of the female reproductive tract. These are nourishment, obviously, for the developing infant. Milk production is the process of lactation. It's controlled by hormones. They lie directly over the pectoralis major muscle. They're embedded in pectoral fat, which is deep to the skin, and they're supported by a band of connective tissue called suspensory ligaments. The glands are divided into lobes. Each lobe is divided into lobules. Each lobule is made of secretory alveoli. Kind of like the lungs, right? Alveoli. The ducts from the lobules converge into what's called a lactiferous duct. The lactiferous duct forms an expansion near the nipple, and they form something called the lactiferous sinus. The nipple is the conical projection where 15 to 20 sinuses open to the surface. You know, if you've ever been a female, if you've ever nursed, that there's more than one hole, and that it's not just on the front. It's not just one little hole in the front. There's several of them, and they all come out in different directions, kind of spraying. I nursed my children for a few years. I had 2 children. So it was interesting, and I didn't really know what to expect, but I really enjoyed it. I don't know if it might sound weird to you, but if you're a mom and you've ever nursed, you know what I mean. It can be painful at first, but once you get the hang of it, it's a pretty amazing thing to be able to feed your child from your own body. Kind of crazy. The reddish-brown skin around the nipple is called the areola. Has a grainy texture because it has sebaceous glands, which have antibacterial properties deep to the surface. Here you see what I mean. The suspensory ligaments holding everything in place. These are the ones that get stretched out. This is why you get a little saggier as you get older. And after you have nursed, obviously, because they've been stretched out from all that milk being in there. The lobules, the lactiferous ducts draining into lactiferous sinus, and then the nipple with several openings on the areola. You can answer these 3 questions by pausing the video and going back and reviewing. So everything in the female reproductive tract is controlled by hormones. There's lots of cycles. There's an ovarian cycle and a uterine cycle, and these cycles are controlled by hormones. There's 2 cycles, and they have to be in sync in order for reproduction to occur. Monthly hormonal fluctuations can cause physiological changes that affect our body temperature. During the luteal phase, you have high progesterone. During the follicular phase, you have high estrogen. That high estrogen is going to cause your basal body temperature to drop during the luteal phase. And this is why several pregnancy predictors or ovulation predictors will include a basal body thermometer, so you can actually check to see when your body temperature drops. So let's talk about the menstrual cycle or the uterine cycle first. This begins at puberty. The first cycle is called menarche. It typically occurs around age 11 or 12. Averages about 28 days from or from 21 to 35 days. Every woman's a little different. Cycle continues until menopause around age 45 to 55. The regular cycle can be interrupted by stress, starvation, pregnancy, illness, etc. So let's take a look at this regulation. This chart pretty much summarizes all of it. You have your GnRH levels, FSH and LH, pretty constant, and then just before ovulation, FSH is dropping, LH is surging. Remember, LH is what's causing ovulation to happen, right? It's kind of the cheerleader of ovulation. And then just after ovulation, that drops. Our follicular phase, everything's developing. LH and FSH are encouraging this development of the follicle. That surge of LH is going to cause ovulation to occur. If we look at our ovarian hormones, inhibin, estrogen, progesterone, there's a surge of estrogen just before ovulation. That's because LH is encouraging estrogen to be released. It's all related to ovulation. Inhibin is released at that point too, because inhibin is telling the pituitary, we don't need FSH and LH anymore because ovulation just occurred. Shut it off. Progesterone remains high, or surges, I should say, after ovulation. That's the job of the corpus luteum to produce that progesterone. Look at what's happening in the uterus. The beginning, because the uterine cycle, ovarian cycle are all marked from the first day of your period, the first day of menses. So this is menses occurring, and after menses is done, the uterus will continue to rebuild itself. After it's rebuilt itself up about 60% of the way, that's when ovulation occurs, because it takes about 4 more days for that egg to get down into the uterus. So at that point, our uterus continues to secrete and encourage its own growth and blood vessel formation, etc. And then hopefully that egg is fertilized and implants, or maybe hopefully it does not, depending on what you want in your life. So also take a look at the basal body temperature. It is relatively low, drops, and then goes back up during the secretory phase. So you can pause the video here, go back and answer these 3 questions. Let's talk about some diseases associated with the reproductive tract. You have fibrocystic disease. This is when the mammary glands are stimulated by reproductive hormones. The changing hormone levels can cause inflammation in the mammary glands. There can be cysts that are formed by inflamed lobules that are formed off of scar tissue. So the clusters of cysts are felt as masses. It's called fibrocystic disease. It's a benign condition, but it could make you feel like you were diagnosed with breast cancer because you found a lump, and that's always a little scary. But just know that not all lumps are breast cancer. Breast cancer is the malignant metastasizing tumor of the mammary gland. It's the leading cause of death in women ages 35 to 45. It's most common in women over 50, and the risk factors include family history, first pregnancy after age 30, early menarche, or late menopause. Treatment is surgical, along with chemotherapy, radiation, and hormones. The removal of the tumor may involve the removal of all or part of the mammary gland, as well as your axillary lymph nodes, which is typically where they metastasize to quickly. This is fibrocystic disease, not breast cancer. The ovarian cancer is the 3rd most common reproductive cancer among women. It's most dangerous form of reproductive cancer because it's very difficult to diagnose early. Because your ovaries aren't sampled. You know, you have cervical cancer being sampled, once a year or whatever at your annual checkup, but you do not have your ovaries being sampled. So, and most women will just, if we have issues with our periods, with our monthly cycles, we'll just say, oh, it's because I'm stressed, or maybe you don't even notice that you didn't get it, right? So the prognosis of ovarian cancer, if it's originating in the general ovarian tissues, or abnormal oocytes can develop, or you can have a relatively good prognosis. So it can go either way. 85% of ovarian cancers are carcinomas, and remission occurs in about 1/3 of all cases. So it can be very dangerous. Most common cancer in reproductive system, ages 15 to 34. So this is a fairly young occurring cancer, cervical cancer. Of 13,000 diagnosed with invasive cervical cancer, about 1/3 will die from the condition. Another 35,000 cases are diagnosed with a less aggressive form. HPV, human papillomavirus, is responsible for 75% of all cervical cancers. So there is a vaccine for HPV, and you can get that beginning at age 12 or 11. There's cervical cancer. It's highly easy to detect because you do go in for those annual checkups once you become sexually active, or once you start getting your period. Sexually transmitted diseases are transferred from individual to individual through sexual intercourse or sexual activity. There's dozens of bacterial, viral, and fungal infections, including chlamydia and AIDS, 15 to 24 million new cases of STDs in the United States each year. Half of those cases are in between the ages of 19 and 24. Ugh, be careful, guys. Contributors to the problem include poverty, intravenous drug use, prostitution, and drug-resistant pathogens. Oh, that scared me. You can pause the video here, go back, and review this section. Let's talk about some birth control strategies. First, there's the male condom. It's probably the most common, right? Covers the shaft of the penis. It basically intersects any sperm from going into the female reproductive tract. It also helps protect against STDs because there's no skin-to-skin contact with the sexual organs. There's also a diaphragm. The diaphragm can be used with spermicide. It's basically a dome of latex rubber, and it fits into the female. It has to be individually fitted, so you have to make an appointment to get fitted for it. It's inserted prior to intercourse to cover the cervix, and it has to be coated with that spermicidal jelly in order to be effective. It has a 5 to 7 failure rate, even if it's fitted properly. There's also oral contraceptives like progesterone, estrogen. The pill has a very small percentage rate if it's used as prescribed. It can worsen problems that include hypertension, diabetes, epilepsy because of the estrogen and progesterones that you're putting into your body. There's also an increased risk of blood clots, strokes, pulmonary embolisms in older women, as well as heart disease. Progesterone-only forms of birth control pill, they are available through Depo-Provera or a progesterone-only pill. The uterine cycles will become irregular and basically cease in about 50% of the women, and the problems include weight gain or slow return to fertility with the progesterone-only birth control. IUDs, or intrauterine devices, is a small plastic loop or a T that's inserted into the uterine cavity. It stimulates prostaglandin production, which is a natural spermicide. It can be effective for years. I think you can leave them in for like 8 to 10 years or something like that. There's also the rhythm method or natural family planning. This would be when you're timing your pattern. So you're basing your most fertile period on those days right after ovulation. Those 4-day window or week-long window after ovulation would kind of be the no honey, I have a headache days, because that would be when you're most fertile. Does it mean that you can't get pregnant any other times? No, because as most of us women know, our cycles can be all over the place. There's a 13 to 20% failure rate because women's cycles can be irregular. So you basically just abstain from sexual intercourse during that ovulation time. There's also hormonal postcoital contraceptives, like Previn or Plan B. This is a combination of estrogen and progesterone, or progesterone is taken in very large doses within 12 hours to 72 hours of unprotected sex. So this reduces unexpected pregnancy up to 89%. Progesterone-only pill available over the counter for women 18 and over. So this is, you had sex and it was unprotected, and you're definitely, chances of you getting pregnant, so you take Previn or Plan B. It's not an abortion pill because it's not getting rid of anything. It's just preventing the fertilization from occurring. Vasectomy is also a possibility. This is surgical sterilization. It's possible for males to have their ductus deferens cut and blocked. Typically, a segment is removed. It's not just cut, but they'll take a couple centimeters off so that it can't just grow back together. It does have a small failure rate. There's no disruption in sexual function. Can be performed in the physician's office for minutes. Tell you a little secret, my husband has a vasectomy. I sat in the car with my kids while he went up to the office and had it done. It was pretty straightforward. The spermatozoa are still produced, but they degenerate in the male reproductive tract, so they're not actually released. There's a tubal ligation for females. This is when the uterine tube is cut or tied, or cut and tied. The failure rate is a much higher percent. It requires general anesthesia, but it's still fairly successful. 0.45% is less than 1%, right? Complications are more likely than with the vasectomy because you're actually cutting and tying and going under general anesthesia for tubal ligation, as opposed to a simple outpatient procedure for a male. I told my husband, I grew those 2 kids for 9 months. I nursed them for years. You can have that little cord cut. Maybe I'm mean. I don't know. Seemed pretty fair to me. All right. Here's some different birth control strategies that we just reviewed, and here's your last slide of this chapter. You can stop the video here, review, let me know what questions you have about the reproductive tract, the reproductive system, birth control, STDs, all that fun stuff, and have an awesome day.